Hello everybody, I'm Dr. Hadir Hassouna, Assistant Professor of Pediatrics and Pediatric Intensive Care Consultant in Alexandria University. We will discuss pediatric emergencies. First, the rule in our management is that children are not small adults. They have completely different anatomy, physiology, and even the pathophysiology of the disease. This is our first. The most common cause of cardiopulmonary arrest in children is, yes, hypoxia. Either it is a hypoxia due to respiratory failure, it is understood that there is no oxygen will enter, or circulatory failure. Circulatory failure or shock means is failure to deliver oxygen and nutrients to the tissues. So there will be hypoxia at the tissue level. So either the hypoxia due to respiratory failure, circulatory failure, it will lead to cardiopulmonary arrest, and which is the most common cause in children. The second rule is prevention is better than cure. The key management of a seriously ill child is early recognition and so early intervention to prevent respiratory or circulatory failure, because once occurred they will be difficult to be reversed. To prevent the progression of circulatory failure or respiratory failure, this means that I have to make a rapid assessment, which is the ABCDE. In what time? In 1 minute. Just to screen the major problem, to make early intervention, to prevent the progression in respiratory or circulatory failure. First, we take A and B together, airway and breathing. Look, listen, and feel. We look for if there is airway obstruction, respiratory distress symptoms and signs, work of breathing, respiratory effort, acting A-Lanizai, working of the accessory muscles, coastal retraction, subcostal retractions. If I have also the respiratory rate, which is very important because it's a very early sign of respiratory failure or impending respiratory failure, is tachypnea. Why? Because I have to deliver the same amount of minute ventilation, and minute ventilation, as you know from physiology, mean minute ventilation equals respiratory rate multiplied by the total tidal volume. So if the tidal volume decreased, so the respiratory rate will increase to maintain a minute ventilation. Okay, but this is for a lesser extent. Then after that it will decline because the muscle will be fatigued, right? So its first will be tachypnea, and is the very early sign of respiratory failure. Then it will decline slowly to be bradypnea and then respiratory arrest. Also we can hear inspiratory stridor, expiratory wheeze, okay, and we auscultate the air entry rapidly in 4 different places, anteriorly and posteriorly, and it's very important to auscultate the axillary part, because if the air have entered the axillary part, this means that the lung is well irrigated. Okay, as you notice here, cyanosis is the least one in the list, because cyanosis, it is the latest sign of respiratory failure. It is the late sign of respiratory failure, because what the meaning of cyanosis? It is the bluish discoloration of the skin or mucous membrane. If there is 5 grams of the hemoglobin is deoxygenated, this means that if the child is anemic, his hemoglobin is 7 or 8, to be cyanotic, 5 grams of his hemoglobin should be deoxygenated. This means that more than 2/3 of his blood to be oxygenated. This is very fatal. Okay. And also it's not a reliable sign in case of polythysemia, because all the time they have 5 grams deoxygenated and they are well and good because they have polythysemia or something like that. So it's not reliable in polythysemia and in anemia, and it's a very late sign. Okay, and we put the pulse oximeter to measure the oxygen saturation. If it is more than 94%, this means that AMSAS for the patient is good. Between 90 to 94, this means that he is unstable and should be monitored at the hospital. At less than 90 is very serious, and he may need assessed in pediatric intensive care. Then we assess circulation. As respiratory rate is the early tachypnea is the early sign of respiratory failure. Also, tachycardia, increase the heart rate, it is the earliest sign of shock or circulatory failure, because we have cardiac output equal to tidal stroke volume multiplied by the heart rate. What means the stroke volume? Stroke volume, the amount of blood pumped from the blood each time. So the stroke volume multiplied by the heart rate. If the stroke volume decreases due to dehydration, blood loss, anything else, this means that the heart will be beat more to maintain the cardiac output. But so for a while, then it becomes fatigued, and then become bradypneic, and then cardiac arrest. We also assess pulse volume. If it is weak, thready pulse, this means that there is poor perfusion. Capillary fill time, we do it on the nail pen. We press for 5 seconds and then release. If there is refill within 2 seconds, this is normal. More than 2 seconds means there is a sluggish or slow circulation, poor perfusion, and so this make prolonged capillary fill time. And we should also repeat it on the sternum, because sometimes cold weather, the patient is near drowning and his cold extremities will be deceiving you, so you have to repeat it in for the child in the sternum and count for 5 seconds, then release. As we notice here that the blood pressure, it is the latest to be affected here in circulatory failure. Why? Because children have compensatory mechanism which increase the systemic vascular resistance. If they feel that there is hypovolemia or intravascular volume is contracted, there will be reflex increase in the systemic vascular resistance, and this will make you, when measuring the blood pressure, will be normal till the end. But if the child you are treating became hypotensive, or he was already in hypotension when the first presentation, this means that this is very dangerous and this is a late sign. Then the disability, we mean the level of conscious. We use AVBU scale because this is a rapid scale. We cannot use glycoma scale because it will take time. As you remember that ABCDE will be done in 1 minute. A mean alert, V response to verbal stimuli, P response to pain, U is unresponsive. Then the posture is very important. A normal child can usually move his hand and legs all the time, but if he is hypotonic or flaccid, this means he is very bad. And if he is in the decortical position or decerebrate position, this means that is very bad injury for the brain. Then the pupil size, which is a very important part of examination. If it is midway and reactive, this means the child is good. But if it is fixed dilated, this is very bad indication that is a severe insult to the brain. And if it is unequal pupils, this means that there is insult to one side more than the other, either hypoxia, trauma, hemorrhage, whatever. Then E mean exposure. If the child have different bruises on his body or different injuries, this means the child abuse. If he has the clothing of the child, if it's soaked with kerosene or gasoline, this means that the child exposed to toxicity. And if there is caustic soda burn on his face, this means that he have is drinking a caustic soda. Also his color, his temperature, okay, his features, this is very important. The second topic is respiratory failure. To understand respiratory failure, we have to understand what is respiration. It is the gas exchange, either oxygenation to take in oxygen or ventilation to get rid of CO2. Any defect in any one of them will lead to respiratory failure. So if there is respiratory failure, there is failure of gas exchange, and will be hypercarbia or hypoxia or both of them. The cause of respiratory failure is alveolar hypoventilation. The child has a central problem or myopathy, neuropathy, anything that affects the chest excursion of the child. If there is diffusion impairment, as you know that diffusion occurs passively, so if the membrane is thickened between the alveoli and the capillaries, will lead to a difficult gas exchange or avoid the gas exchange, like in cystic fibrosis or sarcoidosis. Also, if there is intrapulmonary or cardiac shunting, the blood will pass from the right side of the body, which is deoxygenated, to the left side of the body without passing over the lung or the heart, like the transposition of great vessels. Also, if there is ventilation perfusion mismatch, this means that the alveoli here, we find that the oxygen in the alveoli is reach 100%, and the perfusion should be here good, so that gas exchange can occur by diffusion depending on concentration gradient. But in case of pulmonary embolism, here there is perfusion is very bad, but the oxygenation can reach 150%, right, in the alveoli, but without any benefit. There is VQ mismatch. Also, if there is, in case of pneumonia, is occlusion of the alveoli, there will be diffusion till this, the oxygen in the blood equals the oxygen in the alveoli, so there is no more gas exchange, although there is increased perfusion or hyperemia in the lung. In case of bronchial asthma, both will occur because the alveoli are very tight and hyperinflated. It will compress on the vessels. There is VQ affection or perfusion affection, and later there is ventilation affections, and there is ventilation perfusion mismatch. What is the clinical feature of respiratory distress in children? If moderate affection of respiratory distress, there will be tachycardia. Also, there is tachypnea, respiratory rate more than 50, or according to each child, but more than 50 for any age. This means that it is seriously tachypnea. If there is nasal flare, what do you mean nasal flare? The child will increase the diameter of his nose or nasal ila nasal to decrease the resistance of air, to decrease the resistance to air, so that he can smell or can take in more oxygen. Okay. And grunting, what do you mean by grunting? This is a expiration against semi-closed glottis to increase intra-alveolar pressure for better gas exchange. This is a compensatory mechanism also. Using of the accessory muscles, and there's intercostal, subcostal retractions, and chest indrawing, okay? Head retraction or head bobbing. The patient is unable to feed. All of these are the moderate respiratory distress features. Severe symptoms, as we said, that cyanosis, of course, with a very late sign. The patient is exhausted and unable to do chest excursions, so they have shallow breathing, reduced conscious of level because decreases the saturation less than 92% despite oxygen therapy, and also rising of the partial pressure carbon dioxide. He cannot get rid of CO2. There is CO2 retention. To treat respiratory failure, we give oxygen therapy either by oxygen mask. It will provide oxygen up to 60% for the child, or can use nasal cannula. It's better fitting according to the size of the nose of the child, because we have infant, child, larger child. It will give me concentration more than 80. But if there is respiratory failure, and the muscles are fatigued, so I have to give non-invasive ventilation using ambo bag to give positive pressure ventilation for the child until he reach for the BICU for high flow inhaler or for endotracheal intubation and mechanical ventilation. The size of the mask for the ambo bag is very important. The correct size, it has to pass from the nasal bridge here to the chin of the child. If it's too large, there will be leakage. If it is small, it will not feed the child, and there will also be leakage, and this will lead to inadequate oxygenation to the child, because most of the air from the ambo bag will go outside, will not reach the lungs of the child. The correct position is C and E position. C, we hold the mask on the face and the nose like this, this picture here, and E, as if the finger is making a figure E, a letter E, and is holding the jaw of the child in a sniff position, in a neutral position to open the airway. And if they have a colleague can help me to press on the trachea here, on the cricoid cartilage, we call it cricoid pressure or celiac maneuver, to decrease this air to pass to the esophagus, and most of the air will go to the trachea. So the amount of the should be according to the child. So the bag should feed the child. If it is infant, it will be have a liter, or larger child will be 1 liter or 2 liters according to the size of the chest of the child. If you use so small bag, it will not make me adequate chest excursion, and if it is too large, it will make pneumothorax. So it's very important to avoid excessive volume or pressure. As we said, cricoid pressure will reduce the gastric inflation. So if I didn't do it, or there is air swallowing in the esophagus, I have to deflate the stomach by nasogastric. gastric tube. If we are to rescue, we have to make double C and E position. Double C and E. One of the rescuer is holding the mask by the 2C by two hands, and the two E's holding the jaw carefully so that he take the position in a sniff position. So the other rescue will press the manual resuscitator in the back, and for proper and more chest inflation and better without leakage. Okay, for an adequate chest expansion. Bag and mask ventilation is as effective as endotracheal intubation. This means that if I have to do ambo bag for a child, this will be as effective as endotracheal intubation, unless I'm doing this is a careful fitting of the mask and using the adequate bag for inflation and making the cricoid pressure or deflating the stomach. This will adequately inflate the lung and adequately aerate the lung. So it's very important to know that bag and mask ventilation is as effective as endotracheal intubation. Until that, keep smiling, you are saving life. To know how to make ambo bag for a child, and it will be practice on clinical parts, you can save life when you are in ER or you are facing a seriously ill child. The third topic today is circulatory failure or shock. Shock is present when circulation is inadequate to meet the metabolic demand to the tissue. This is failure to deliver oxygen and the nutrients to the tissue, and there will be tissue hypoxia. Type of shock: either hypovolemic shock, distributive shock, which is sepsis or anaphylaxis, cardiogenic shock, neurogenic shock. The clinical feature of shock different according to the timing of presentation. If it is early in the compensated stage, tachycardia, as we mentioned before, it is the earliest sign of shock or the earliest sign of circulatory failure. Also, there will be tachypnea, decreased skin turgor, sunken eyes and fontanelle, delayed capillary fill time more than 2 seconds, mottled, the patient is mottled, pale with cold skin. The core to peripheral temperature gap is more than 4 degrees Celsius, and decreased urinary output less than 1 ml per kg per minute per hour. The late or decompensated stage, there will be acidotic stage, acidotic breathing, which is cosmal breathing, bradycardia, because there is a fatigue of the heart. Okay, as we mentioned, the first tachycardia, then bradycardia can occur. Confusion or depressed, or the patient's cerebral state is not well. Blue peripheries because there is poor perfusion. Absent urine output, complete oliguric, and hypotension. As we mentioned before, it is the late sign of shock. So the early sign of shock is tachycardia. Late sign of shock is low blood pressure. And it is important to recognize early compensated shock as it's reversible, in contrast to the decompensated shock, which may be irreversible. Dehydration. The prevention of shock from dehydration rely on its early recognition and treatment. One of the causes of shock is hypovolemic shock due to dehydration. So I have to early recognize this dehydration to prevent its progression to shock. Causes of dehydration: either gastroenteritis, burns, sepsis, diabetic ketoacidosis, diabetes insipidus, nephrotic syndrome, or poor fluid intake. The degree of dehydration depends on the amount of weight loss, amount of body weight loss. If there is no clinical detectable dehydration, this is usually less than 5% of the loss. Less than 5% loss of the body weight. If there is clinical dehydration, this means that it's from 5% to 9% loss of the body weight. The state of shock when more than or equal 10% of the body weight is lost. Also, this is the table is present in your book. Different items according to the no dehydration state, clinical dehydration, and shock. We should notice the red flag sign is very important. This with the child with appearance of unwell or deteriorating, irritable or lethargic, with sunken eyes, tachycardia, tachypnea, and reduced skin turgor and decreased urine output. This is a very dangerous sign that the child is progressing to shock. So I have to treat at this time aggressively and to prevent the progression to shock. The most accurate measure of dehydration is the degree of weight loss during the period of illness. I will not depend on only sunken eyes or only the skin turgor, because the patient with marasmus or the patient with nephrotic syndrome, we have general edema, this will be difficult to assess, right? So the degree of weight loss is very accurate to measure the dehydration degree. Fluid management. It divides on fluid resuscitation, fluid deficit replacement, maintenance fluid, and ongoing losses. Initial fluid resuscitation, first we give a crystalloid, or if there is the hypovolemia due to blood loss, I will give blood for 10 ml per kg. Okay, if there is improvement, then I correct the hypovolemia and collect the causes and to treat the white deficit and maintenance later on. But if there is no improvement, I will repeat the shot again, and the child now will need intensive care units because there is massive loss of fluid and the patient now in shock. Children who require more than 40 ml per kg of resuscitation fluid are likely to require mechanical ventilation. So it is important that if the child take more than 2 shots of fluid, he is progressing to shock. So I have to send for a pediatric intensive care unit, and he may need mechanical ventilation. Then the fluid deficit. Assessment of the volume of fluid needed to restore circulating volume after resuscitation, and then I do resuscitation, given shot 2, 3, the 4 shots according to resuscitation. After resuscitation, I assess for the amount of deficit. Okay. Assessment of the according to the clinical feature. If there is clinical dehydration, moderate to, this means that is moderate to severe dehydration. There is 5% deficit. I will give him fluid deficit 5% of his weight. If the patient is shocked, this means that there is severe dehydration. There is 10% deficit. Change in the weight where an accurate pre-morbid weight measurement is available. This is very important to know his initial weight. Fluid boluses given during resuscitation are reduced from the fluid deficit. If he take 20 ml per kg during resuscitation, I will subtract them from the fluid deficit replacement, not to make overload fluid, because to give more fluid is also harmful, because fluid is a medication and any medication have a side effect. So giving too much fluid, then the patient will have side effects. Then the maintenance fluid. For the first 10 kilos, we give 100 ml per kg fluid. For the second 10 kilos, we give 50 ml per kg. For every 1 kilo after that, we give 20 ml per kg of the body weight. So the total fluid required in 24 hours, I will measure it, and will give it for either sodium chloride with 5% dextrose, we call it D5 normal saline, we call it like that, and we add, also we can add a 20 millimolar potassium chloride for every 500 ml, or we usually use 40 millimole potassium chloride for each liter, okay, provided that the patient is giving urine out. The patient is anuric or oliguric, it is very dangerous to add potassium chloride. But if the patient is giving urine now, you can add potassium chloride. Okay, take care. Then ongoing losses, either vomiting, losing fluid, hemorrhage, diarrhea, or the patient is DKA and he is polyuric. All of this is the ongoing losses. It is measured time by time, every hour, how much he lost, and then I replace adjusting fluid. Very important that fluid adjusted according to the clinical situation. There is risk of SIAD. This is the syndrome of inappropriate antidiuretic hormone secretion. For example, in case with pneumonia, 2/3 of standard maintenance should be given because there is a higher risk to have SIAD. Either replacement will be enterally or intravenous, yani by mouth or intravenous line. Maintenance fluid may need to be increased to take account for ongoing losses. If the child have fever, if the child have tachypnea, if the child in a ventilator with a humidifier, all of this can affect the amount of fluid the child can take. Maintenance fluid are reduced to take account for oral intake. If the child can take oral, I will give him oral. But if he cannot, because he is unconscious, if he have difficulty in swallowing, if he is vomiting everything, then I will give it IV fluid. Fluid replacement time increased up to 48 hours to avoid rapid change of osmolarity, as with hypernatremic dehydration or diabetic ketoacidosis. It's very important to avoid brain edema if I give the fluid very rapid. Okay? Don't forget, early sign of shock is tachycardia and late sign of shock is low blood pressure. And it is important to recognize early compensated shock as it is reversible, in contrast to the decompensated shock, which is maybe irreversible. The last topic with us is anaphylaxis. It's a severe life-threatening condition. Anaphylaxis is a severe life-threatening condition, sudden onset of systemic allergic reaction, triggered by different triggers, but the most important trigger in children is the food, either peanuts, eggs, milk, and this is common for children. But insect bites or pollens, and this is more in adults than children because they are not exposed like a adult. To diagnose anaphylaxis, it is an acute onset of illness, life-threatening problem. So I have to check A, B, C, D, E. Okay? A, the swelling of the airway will make hoarseness, stridor, the patient is struggling, respiratory distress. The breathing will be tachypnea, wheezing, fatigue, and cyanosis. Saturation will be less than 92%. If circulation also affected, he is pale, we have hypovolemia because there is distributive shock. There is severe vasodilatation acutely. This leads to the hypotension. It's very common to occur in anaphylaxis. Disability, the feeling of sometimes fainting, drowsiness, and coma. The skin or the exposure, we look for urticaria rash, okay, wheals and redness, okay. We lie the patient flat first and raise his leg in attempt to increase the blood reaching the heart for more or better venous return. But it's the effective treatment, or the only treatment, is adrenaline intramuscular every 5 minutes until clinical improvement. This is the gold standard of the treatment. To give adrenaline intramuscular every 5 minutes until clinical improvement. Then at the same time we have to establish airway, high flow oxygen, give fluid challenge, because intravascular volume is distributed, they go outside the vessels. May give chloramphetamine, may give hydrocortisone. The patient should be monitored for pulse oximeter, ECG, and blood pressure. And it's very important that to know and to emphasize that intravenous adrenaline infusion, if 3 cycles of the intravascular adrenaline fail, to stabilize the patient. So if after 3 shots intramuscular and the patient unstable, I should give him intravenous adrenaline infusion. Then after all this, if we cannot prevent all this shock, respiratory failure or anaphylaxis, and the patient unfortunately in a cardiopulmonary arrest, what should we do? First, to diagnose cardiopulmonary arrest, should we have absence, a palpable pulsation in the major artery, unconsciousness, and apnea. All the 3 occurs together. We discuss the pediatric basic life support. First, basic life support, who can do it? Anyone, yes, anyone trained for basic life support should share in the basic life support. Car drivers, teachers, the student at schools, the student at universities, anyone trained for pediatric life support with no equipment. First is the safe approach. And if you are saving life, you have to protect your life because you are the rescuer, okay? To be sure that there is nothing is bombing, nothing is falling from a height, there is no smell of any poisonous gas. If so, you can move the child to a safe area to start CPR, okay? And then we have two scenarios. If you are alone, okay, you will check for responsiveness, okay, stimulation gently, flickering the child gently كده from his chest or his shoulder to avoid طبعا head trauma or excessive or vigorous movements, and shout for help, 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 okay, because someone can hear you from a far distance, can come and help with you. But if you are the scenario that you are not alone, there is another audience present, you can ask help of them. You assign someone to call the police or to call the ambulance, and the others you can tell them what to do because you are the team leader now. After that, shouting for help, and we open the airway by head tilt chin lift like this, and or you can make a jaw thrust. We'll show it later. If we suspected that there is injury of the spinal cervical spines, and if I make head tilt chin lift will lead to injury of the spinal cord, so I will not do it. And then I will check for breathing for 10 seconds. Look for chest movement, listen for the breath sound, and feel if there is any air coming from the patient's nose or mouth. If there is no breath, or the breathing is no breathing or abnormal breathing, just gasping, now the child will receive 5 rescue breaths. How they receive 5 rescue breaths? Using mouth to mouth. I will show it later. If the child, I suspect that he has cervical injury, I will do jaw thrust. If he is infant like that, I put my hand behind his jaw and I raise it upward according to the child as mentioned here. But if he is the older child, I will move the jaw toward me like adults. Mouth to mouth breathing, I will give it, if the child is an infant, I will put my mouth on his nose and mouth together and give him as deep possible, as fast possible, to make chest rise for this child. But if he is older child or near adult, I will pinch his nose and give it mouth to mouth. Of course, this is something disgusting, but you are saving life. And if you are in an army or you are going to a place that you suspect to see this problem, I can use a plastic bag with a valve or something like that, but we can put your clothes, your handkerchief or something like that. After giving 5 rescue breaths, now I'm checking for life. I check for life, head tilt chin lift, look, listen and feel, and now I'm putting my hand on the pulsations in the carotid or the femoral for children more than 1 year old, or the brachial or femoral if the child is less than 1 year old. If there is no pulsation or the pulsation is less than 60, this means that there is no adequate pulse, and we start chest compression. Here the pulsation, to assess pulsation. If there is infant, I would assess pulsation in the brachial artery, but if he has a neck, an older child, he has a taller neck, I can test or assess the pulsation in the carotid against cervical spine. As you know that pulsation should be assessed against bone, so the carotid will be assessed against the cervical spine and the brachial against the lower part of the humerus. And if it's the femoral pulsation, if I can expose the femoral part, so I assess the femoral pulsation against the head of the femur. Now we are doing chest compression. To do the chest compression adequately, you have to understand what we are doing, what is the mechanism. When the child is alive, the force that pushes the blood along the circulation is the cardiac pump. But if this cardiac pump is not working, now we are creating a thoracic pump by the chest compression. We are moving the sternum towards the vertebral column to squeeze all the organs so that this cardiac output comes out of the heart, and then I release again to the normal position, so I create a negative pressure, so this organ, which is the heart, will retake again venous return for the second cardiac output. Okay? Why we are doing this? Because we need to keep coronary perfusion pressure normal. We were normalizing the coronary perfusion pressure, which equals to the aortic diastolic pressure minus the right atrial diastolic pressure. The right atrial diastolic pressure, it is not, I cannot control it, but I control the aortic diastolic pressure by my effective chest compressions. If the child is infant, if there is an infant or less than 1 year, I will circulate my hand like this, or by 2 fingers if I'm a single rescuer. If he's a larger child, I will do hand chest compression, and as we notice that the rescuer is above the patient because he has to straighten his arm, and all the compression came from his shoulder girdle and his trunk. If he's older child or your hand is fatigued or small hand, you can do it by 2 hand technique like this, like a lever technique. From your chest, from your shoulder girdle, from your back, from your trunk, all the compression, because I need to decrease to make the chest compression hard as possible, half or 1/3 the anteroposterior diameter of the chest. So it's very important to have high power to do this. So the key to generate effective cardiac output during cardiopulmonary resuscitation is to push hard as to compress as half or 1/3 the anteroposterior diameter of the chest. Push fast as what? Fast as 100 compression per minute. Release completely, which is very important for recalling or sucking or taking again venous return to the heart. So the heart will be filled again, so that second compression will push a good cardiac output. The fourth rule is do not interrupt compression unnecessarily. Don't stop compression to call for help. Don't stop compression to talk to your colleagues. You have to complete your compression. If you are one rescuer, you will do 30 compressions to 2 breaths, and if you are 2 rescuers, is 15 compression to 2 breaths. Why it's very important not to interrupt, and why it is 15 to 2, not 5 to 1? Because if it is 5 to 1, after you are reaching the normal coronary perfusion, you stop for breath and then you will decline again. But if you give 15 compression, this means that you are maintaining a normal coronary perfusion pressure for a longer plateau, and this is what we need to make the heart again spontaneously contract. Okay? During resuscitation, we have to search for the reversible causes of arrest, which are the 4H and the 4T. 4H, as we told you, hypoxia is the most common cause of arrest in children, hypovolemia, hyperkalemia, hypohypernatremia, calcemia, metabolic acidosis, hypoglycemia, all of them are present in this item. The fourth H is hypothermia. 4T is the tension pneumothorax, thrombosis, either coronary or pulmonary, cardiac tamponade, and toxic or therapeutic disturbance. Most of the time you have to correct more than one cause, because the child is hypoxic, hypovolemic, and hypothermic. He is he will make by ambu bag, he have tension pneumothorax. So you have to treat all the reversible cause of arrest during your CPR, so the child can turn back to life, inshallah. My question to you now is: in-hospital arrest better prognosis than out-hospital arrest, or the reverse? In which whose prognosis will be better, in hospital arrest or out-hospital arrest? Yes, the in-hospital arrest. Although in the out-hospital arrest he is completely normal, he is going and without any disease, but in hospital arrest he has pre-morbid condition, but also in the hospital he is monitored. There is ECG monitor in the CO2 pulse oximeter laboratories, and I'm ready for his arrest. So why, although he is have a premorbid condition, his prognosis will be better? Because I will start chest compression or start CPR immediately after arrest, right? The brain can withstand hypoxia for 4 minutes. In some books they write for 5 minutes, but I prefer to use 4 minutes. The brain can withstand hypoxia. If I resume circulation again, either spontaneously or by chest compression, the brain perfusion will be not affected, right? Of course, the 1 to 2 minutes is better than 3 to 4 minutes. Within seconds is better than within minutes. Okay? So the brain can withstand hypoxia for 4 minutes. From 4 to 8 minutes, the child will come back to life, but of course with a profound brain injury. After 10 minutes to resume circulation, the child will not return back to life, or he will return in a brain death state, which is worse than being dead. Okay? So the in-hospital arrest prognosis will be better. Why? Because we will start CPR as soon as possible, and this will preserve the brain normal. Any questions, comments, or concern, don't hesitate to call me or send on WhatsApp number here written, or send me on my email. Remember, CPR training is very important. When you get trained, you will save life, and you will do, and be glad to do that. Thank you very much.